Well, Andrew, I feel like Marco Rubio in the last debate, very timely. But I think it's interesting. I was sitting next to Ed Felix, and everything changes, and nothing changes. The one thing that I think is the same is that we have a lot of the same discussions, and much of what we say is anecdotal. A lot of it should be more than anecdotal, but it's not always. So, let's see here are my disclosures. So, robotics in hernia surgery. I mean, there's definitely been an acceptance and an acknowledgement that a robot can be used for doing a lot of things. We have to consider cost always. How we define that cost, I think, is very different depending on institution and depending on who's talking about it. And of course, value with quality over cost is very important, and the impact of that, whether it's from the patient, the surgeon, the healthcare system, or the payers. And the question is whether the robot is not just another quiver in our toolbox of something else that we can do. Since the mid-90s, the evolution of MIS in hernia surgery we all know well. I was fortunate to be a fellow with Lee Swanstrom back 20 years ago now, 1994. And at that time, we were beginning to develop techniques along with following people like Ed Felix and Guy Veller of laparoscopic TEP procedures. And soon after learning initially the laparoscopic TAP procedure, many of us in the United States evolved to a laparoscopic TEP. The concept of being preperitoneal and using a balloon was very appealing. MIS as a adoption and an option for hernias became well established, although it is true that over the last 20 years, the penetration of MIS in hernia surgery has stayed relatively flat. Unlike lap choles, which took off resoundingly, laparoscopic hernia repairs has stayed static and had small little blips, probably from fellows and residents learning, but really still at this time only represents about 25% of the hernia market, with most of them being done on the open. Robotics may have been looked at as a fad, that it wasn't really relevant. There have been a number of cases and reports and studies and news media that have captured this, just like we saw badrobot.com. Even Brian Williams on Rock Center, the last episode before that show went off, the lead article, the lead story was about a robotic hysterectomy with a vaginal cuff dehiscence, which was blamed on the robot. I think it's clear that it's not so much the robot, but who's behind the robot that has led to most of these complications. And there have been very, very few, if any, cases that have implicated and proven that the robot itself is to blame. So there's really been a question about the importance of best practice in robotics. There's no question that you can do a robot efficiently and that you can do it cost effectively, but if you don't follow best practices and you don't follow cost containment and efficiencies, then it's going to ruin it for everybody. So we can see the trends over the last 20 years of utilization of open mesh repair for inguinal hernias, for instance, which has dropped down to without mesh, which you can see on this green line, and the concomitant rise in both laparoscopic and open mesh repair, which has stayed at about 75 to 25% respectively up until now. So robotics enabled us to go from TEP to TAP, although some people have been doing robotic TEPs, but I would argue that that probably takes away one of the advantages because it just adds additional costs if you're going to use a balloon for preperitoneal dissection and then dock the robot. About 2010 is when robotic hernia, 2011 when robotic inguinal hernias really began, and it has been the single largest growth in robotic surgery over the last several years, to the tune of about 300% a quarter growth in just the last couple of years. When I started doing robotic hernias in 2012, there were about maybe 50 surgeons across the United States who were doing inguinal hernias, and in this past year alone, we trained more than 1,000 surgeons to do robotic hernia repairs. So what are the potential advantages? We've talked about this a number of previous speakers, but in the inguinal hernia, we can argue that you can have the 3D visualization may facilitate better identifying areas of potential postoperative complications, nerves, vessels. Precise dissection with the robot really makes it a very safe procedure, and some of the complications that we have seen in TEPs or TAPs, some would argue that they might be able to be more safely performed. And the ability to suture mesh and the peritoneum without any other fixation device, whether it's inguinal or ventral hernias, I think many people would argue this is one of the strong benefits, especially in defect closure. Whether or not you are a proponent of defect closure, there's no question that although Dr. Mercedes showed us laparoscopic, and we've done laparoscopic defect closure, there's no question that the facility of having endo-wrist technology along with barbed sutures has made robotic closure of defects significantly easier. So the issue with a robotic hernia repair is that we should hold basically the same tenets as a TAP repair. As many of us know, in the United States, the TEP has been the more popular minimally invasive technique, and in Europe, still the TAP is quite favorable. The times should be comparable, and in most studies, once you've got past the learning curve, we can see that the times should be very comparable to a laparoscopic repair. Potential cost savings. Is there potential cost savings? And again, Andrew and I could argue, and many people could argue about whether you should amortize the cost of a $2 million robot or not. But if we talk just about direct costs, disposable costs, I could argue that we could say that we can do a robotic hernia cheaper than we can do a laparoscopic hernia. But again, we need studies to show this, and the problem is that it's very unlikely to get a large series done, although we are going to be starting a study just for that purpose shortly. This is just to show my, excuse me. This is just showing my own personal results. This is up until about 6 months ago. We now have over 200 cases, but for robotic inguinal hernias, 177 cases, range of age from 18 to, yes, 101. OR times about 25 to 140 minutes. Console times comparable, 17 to 90 minutes. But after the first 35 cases, console time averaged about 30 minutes. Postoperative pain, return to baseline activity, and recurrence was comparable to our cohort of our own laparoscopic TEPs. As far as disposable costs, this is a few different studies or a few different samples for inguinal hernia repair. And as you can see, I would argue that you can do a robotic inguinal hernia for actually at the same cost or even less than a TEP. If you can, now there of course is some variation because of the type of mesh that you use, or whether you use a balloon or don't use a balloon, whether you use glue for fixation or whether you use a tacker, but you can see that it's very comparable. When we do, and it's important to follow best practice. Vast majority, probably 80% of the robotic inguinal hernias that I do, I use only 2 instruments, and the drapes and mesh and everything else added together brings us in at about the same cost or a couple of $100 less than a corresponding laparoscopic TEP procedure. For ventral hernia, similar, and again, there's probably much more variability here because of the techniques and the what type of mesh you're using and what type of fixation you're using. But again, we can argue that you can keep the cost relatively low if you are judicious in selection of your materials and your time. So the question is whether or not robotics is having an impact on hernia, and I think that there's no question you can't deny that it's here. We can't stick our heads in the sand. There's no question that I think, unlike sills, which did have a flurry of interest and has sort of gone away, I think robotics, the future, as Eric Wilson said in a recent article just a couple of months ago in American General Surgery, that robotics is here to stay, that the advances in MIS are going to be coming from robotics. And you can see in just the last few years, and only 3 years of doing any significant volume of robotics, we can see that slowly we are changing the adoption of MIS in hernia surgery. And that change has been directly from robotics. You can see that the increase from the decrease in open and the increase in MIS, you can see, has grown by 4% in only the last 2 years. So what's the other issue? The big issue is cost, and not just the cost of a robot or the cost of the disposables, but the real drive is what this slide is talking about, which is the changes in where the direction of healthcare is going, whether it's from Obamacare or whatever organization or insurance plan you want to talk about. We are in the midst of very big changes. Now, I don't know if anybody here is aware, but in January of this year was the first time that CMS changed the 3-level coding on all CPT codes. So instead of having levels low, medium, and high, CMS decided that they would go to just 2 levels because it was a little bit too complicated. So all of the level 2s, or the middle complexity cases, went to either a high level or a low level. And what that meant is that the reimbursements change, and it's changed in favor of minimally invasive surgery. Some insurance carriers also are pushing the costs and requiring pre-authorization. United Healthcare, January 2016, pre-authorization for any hernia to be done in a hospital. There is a drive more and more, and appropriately, that these cases should be done in an outpatient setting. Now, of course, an outpatient setting doesn't always mean cheaper, because if a hospital has their own ASC, quote unquote, it's really what's called an HOPPS, and that is a freestanding surgery center, but it's under the fiscal responsibility and finances of the hospital, so they get the exact same charges. So from the insurance company, it doesn't matter. What we want to see is freestanding ASCs that are in network. So we can, just 1 second. Okay, I just want to go forward. So this is just showing the drive towards the outpatient, the ASC setting, and hernia and everything else which is going directly in that region. And this is the one interesting thing that should satisfy some MIS surgeons here, is that when CMS changed all of these codes, laparoscopic hernias went up 25% for the facility reimbursement. The open corresponding hernias went down 6%. So this is a significant increase. And of course, cost, we know that the complications of any cases add significantly, and so the question is whether robotics or MIS can significantly help that. The economics for the outpatient certainly is driving more and more towards an MIS approach, and specifically I would argue that robotics has a role to be at least in the same ballpark as laparoscopic. And the big thing that I would say for robotics is that it is facilitating open surgeons to learn how to do hernias. Finally, if we look at this slide, which is very important for anybody who is in finances of a hospital, we see that now in 2016, with the increased reimbursements for facility, open hernias actually are costing the hospital more than a laparoscopic hernia, because the reimbursements are below the cost of doing the cases. By the same token, an outpatient laparoscopic technique is actually a cost benefit to the hospital. So in conclusion, I would just say that I think that robotics in hernia is here to stay. I think that it is likely to become an important quiver in our tools for hernia repair. It certainly has been shown to facilitate open surgeons to get into minimally invasive approach to hernias who would not otherwise be able to take the time to learn a laparoscopic technique. And if we keep to best practice containing costs, I think this can be a very viable alternative to hernia repairs. Thank you.